Okay, I want to go ahead and get started. Thank you for, this session is a lot better attended than it looks. It's a huge crowd, enormous crowd. And that's not even counting all the people that can't get in here. Okay. I want to thank you all for coming to our symposium. I'm not going to read the title of the symposium, but I want you to know we're in the running for the longest symposium title at the meeting. And we'll probably be getting an acrylic for that or something at the third plenary. My name is Dutch Vandevander. I'm a adjunct professor at Case Western University School of Medicine, which I'm told is still in Cleveland. And my co-moderator, Nicole Meyer-Hamblett, is co-director of the TDN and also a professor at the University of Washington. And I want to say a few words about our topic, which is exposure response. And I'll start by way of disclosure. So these are recent companies that I've worked with in the area of CF drug development, and it's more to make a point than to disclose things. If you look at my history over the last 25 years, you'll see there's an awful lot of companies that have dabbled in CF drug development, and in our separate capacities. Nicole and I have worked with all of these, and she's probably worked with more. By the way, if you don't see your name up here, call me and I can get you up here later. I do need to say that I'm on the organizing committee and my registration was paid for by the CF Foundation. So I want to talk just very briefly about exposure response to set the stage. So for biologically active substances, there is this relationship between the extent to which the target is exposed and a magnitude of response. That's not as simple as this picture. We tend to think of these things as sigmoid curves. And there's an area that we're particularly interested in, this highlighted area, where as exposure increases, response increases. And what we're going to talk about today is several aspects of this and how this really can be important in drug development. I want to point out that although we never know exactly what these curves look like, we do know they don't always look like this. Sometimes they can look like this. There's at least one case in CF of a higher exposure leading to a worse response. So understanding these curves, although you'll see we have had a tendency to not do very well at defining these curves for our drugs, can actually be really important in drug development. So I want to talk just briefly about dose and exposure. So we talk about dose response, talk about exposure response, and we use these terms interchangeably. Obviously they mean different things, but they certainly are related. So this is a dose. This is an inhaled product. And this is the thing we control. This is the script we write. This is the thing we look at in clinical trials. This is an exposure. So for obvious reasons, these two things are related, but really not the same. So how much drug is actually at your putative site of action is different than the dose that you've administered. Why is this important? Because the same dose can produce different exposures in different people. I think that's pretty straightforward. And the converse is true also, that different doses can produce the same exposure in different people. So it's complicated. But we tend to focus on dose as drug developers because that's the thing we can control, although we always look at exposure. So Nicole's and my experience, and probably your experience as well, we actually have a really pretty large experience with drug development in the CF community. About, I think more than a quarter of the patients followed in the CF registry have participated in at least one clinical trial, which is remarkable if you think about it. And our paths that we've followed are pretty prescribed. Someone has an idea that there may be an intervention that might improve respiratory health, and once they've jumped through all the hoops to make sure that it's reasonable to expose humans to this drug, we ask how much can we give safely or practically, and we run a dose escalation study. We keep increasing doses until we either get exhausted or we find a dose that people don't tolerate and we back off. And really the very next thing that we do, after raising a little money maybe, is to ask, is there any evidence that we can generate efficacy with this highest tolerated dose? You run a modest study, look at a particular response that is meaningful to us at that dose, and if we have evidence of anything, Traditionally, what's happened in CF is we immediately think, we've got a dose, let's run a phase 3, run roughly the same design, maybe longer exposure with more patients, and we have established a biological response. And for those of you that are long in the tooth, anytime this happened, it was kind of a novelty because we looked at a lot of drugs that didn't do this. But when we got this, we thought, hey, we really accomplished something here. And for most, I would say most of our standard of care therapies, we barely have this much information. But what we don't know is where we are on this dose response curve in this situation. And why is it good to know that? Let's consider if we have this information, we just take one more step and ask what happens if we give a lower dose, and that's presumably a lower exposure. Well, we're pretty smart, so probably there'd be less efficacy. And we would say, aha, we knew this all along, and we imagine a dose response curve probably looks like this. And that's great. And you say, well, maybe that was a waste of time because we already knew that. But I will tell you that this sort of data is really excellent supportive data for a filing because it is another piece of evidence that the treatment is associated with the response. Less treatment, less response. So you shouldn't downplay the importance of this. Even if it's with biomarkers, it's really very useful information. But it doesn't always happen this way. Lower dose is good and it supports efficacy, but what if instead we get the same response at a lower dose? Well, if you don't look, you don't know. But if you do this, what does it mean? Well, now we need to think differently. Maybe we think the curve looks like this now and we're still in a good spot. But the point here is that there's a safety issue here now, because if we have a lower dose with the same efficacy, then the higher dose, the risk benefit's worse. We're just exposing patients to a drug with no benefit that we can see. And so if I were a regulator, which I'm not, I would want to know that we're not on this flat part of the dose response curve going into our commercial run. And finally, and this has happened in CF, the lower dose might be more effective. And now you really need to, I mean, that's great. More efficacy is great, but what we know is we don't know much. Maybe the curve looks like this. But what we've done by just doing that one other data point is we've really become much more sophisticated about our drug. I think you'll see today that sophistication is not really a long suit in CF, but we'd like to formalize what we do. So let's just suffice it to say a lower dose with better efficacy is a better dose, and I challenge anyone to contradict that. So today's symposium, we have 4 excellent speakers, and I will introduce our first. We're really fortunate to have a reviewer from the Food and Drug Administration. Oh, geez, what'd I do? I guess that was good. Dr. Chao Liu, he is a graduate of the University of Maryland, and he is a reviewer in CEDAR and the Food and Drug Administration. So come on up.
Okay, so good afternoon, everyone. So it's my great pleasure to be here today. So first of all, thank for the organizers, modulators here today, so to invite me in this nice weather in Boston. My talk today will focus on the use of exposure-response relationship in regulatory decision-making to support drug approvals. This is my disclaimer today. So my talk today will only represent my personal view on this topic, unnecessarily represent the agency's perspective or regulations. First, I list here some of the commonly cited regulation documents that we use for dose response or exposure response. The first one, SHE4 dose response, I think that's published in 1990s, has been about like 3 decades. In this guidance, I'm not going to read it, but dose response can be used to support dose selections, and it can be used to adjust dose in particular subgroups in terms of like intrinsic factors, extrinsic factors, or any special population or circumstance. The second one is Title 21 Code of Federal Regulation, which is the major tool or the major code that we rely on at the agency to regulate drug development. So in section 201.57, there's a specific requirement for drug labeling in regards to the exposure-response relationship has to be described in the section 12.2 in the US PI for pharmacodynamic response or exposure-response relationship. Well, the last one is technical guidance for industry exposure-response relationship. So in this guidance, we describe like how dose response or exposure response study or analysis has to be done, and some of the regulations related to it. But this is a non-binding guidance. So I think Dr. Winter have to make a very clear, a good introduction for the dose response. So as a clinical pharmacologist at FDA, one of my major job responsibility is to look into dose selection for drug development. So for the general patient population as well as for special patient populations, the major tool we relied on to justify a dose adjustment or to make a decision for exposure change is the dose response or exposure response relationship. So sometimes you have to develop exposure response or dose response for efficacy. Sometimes if there's major safety concerns, you may also have to look into toxicities based on dose or exposures. Here are two examples. I won't go to details, but for liraglutide, for example, which is anti-type 2 diabetes drugs that we approved, the exposure response will be straightforward and there's no much safety concerns. So the dose selection will be easier. You just have to look into the efficacy response in terms of the hemoglobin HbA1c. But sometimes it will be a little bit complicated for anticoagulant drug development. You may want to balance the major bleeding and the stroke. One is efficacy, the other one is considered a safety issue to make a dose selection in those situations. So today I will share two case examples that we experienced at FDA for cystic fibrosis drug development. And the two examples are all related to dose adjustment or exposure matching. The first one is abacavir, the approval in pediatrics patient populations less than 12 months. If you look into the Colideckel abacavir's label, you'll notice that in section 12.3 pharmacokinetics, we have a table that lists all the age group and body weight cohort as those we approved or recommended for the AUC or exposure metrics we observed in clinical studies. Abacavir was approved first in adult, adolescents, and children 6 years and above based on efficacy and safety studies. So on the bottom for 12 years and older adolescents and adult patients, we highlight their exposure levels. That will be around like 10,000 for AUC. In children below 6 years old, particularly we're going to talk about those neonates and infants below 12 months of age and body weight below 7. In those 4 cohorts we highlight on the top of this table, if you look at their exposure was about like 5,000, which is 50% lower than the adult exposure levels. And those approval was based on exposure matching without efficacy double-blinded study. So why those lower exposure is considered efficacious in those younger kids will be the topic I want to discuss in this case example. If you look into the study design for the pediatric study, those studies are open label study that mainly focus on describe the pharmacokinetics and pharmacodynamics as well as characterize the safety profile in those younger kids. But safety was not established or evaluated in those studies. The dose study in this pediatric study, which supported approval, basically use the dose that we approved in the current USPI label. And like I said previously, for those younger kids, their exposure is much, much lower, like 50% lower than the adults and adolescents. So as a clinical pharmacologist, normally we believe like 50% exposure, lower difference or one-fold difference will require some dose adjustment, either for efficacy or safety. In this study, first of all, the observed sweat chloride reduction at 24 weeks was similar to the adult observed magnitude in those younger kids. So their PD response was similar to adults. So in the adult study, which is reviewed in the original approval, is a randomized, double-blinded, placebo-controlled study. So this study established a dose response. So in this study, they evaluated the 25 milligram, 75 milligram, 150 milligram, and 250 milligram dose at the BID dosing. So 150 milligram BID is the approved dose. And in this study, they characterized the sweat chloride as a PD marker and the ppFEV1 as the efficacy endpoint. So based on this adult dose ranging study, in the figure, you can see that for 25 milligram dose, the efficacy response for the ppFEV1 looks similar to placebo, which means at 25 milligram dose, it doesn't work quite well. There's no efficacy. For the other three, 75 milligram, 150 milligram, and 250 milligram dose, they respond quite similar. So there's a flat dose response from 75 to 250 milligram dose. 75 milligram dose had a 50% lower exposure than the 150 milligram dose, which is similar to the pediatrics, the younger kids exposure level. So based on this dose response, we consider the lower exposure in those younger kids are still efficacious. This still can provide efficacy response. So that's the reason, even though the exposure is lower, we support the approval in this younger pediatrics group for the dose we approved in the label. Secondly, I would like to switch the gear a little bit to fixed dose combination. So we have now approved like Orkambi or like Trikafta. So those are like dual therapies or triple therapies. So based on the Title 21 Code of Federal Regulation, it requires each of the components in the combination product contribute to the claimed effect, which means like the sponsor have to show that each subcomponent is efficacious to the patients. In this example, is lumacaftor plus avacaftor for Orkambi. Lumacaftor is a strong CYP3A4 inducer, and avacaftor, which is approved previously for monotherapy, is a CYP3A4 substrate. So when co-administered lumacaftor with avacaftor, lumacaftor decreased avacaftor exposure by 60 to 75%. If you remember the exposure or dose response relationship for avacaftor I mentioned in the previous slide, at that level, roughly, I think 150 times or 1/4 is like 40 milligram dose, avacaftor may not be efficacious. For that reason, the dose for avacaftor was increased from 150 milligram dose to 250 milligram dose. But even with the 250 milligram dose, when co-administered with lumacaftor, the avacaftor's exposure is still 60% lower than the monotherapies 150 milligram dose exposure. So again, this is the dose response we were talking about previously. For avacaftor, 50 milligram, 250 milligram dose had a corresponding exposure about like 60. So it's close to 75 milligram dose, which may reach to the plateau of the dose response relationship. So I would like to interpret like the result, why the dose response or the exposure levels support the use of avacaftor in combination with lumacaftor. First of all, in vitro studies shows that lumacaftor, which is a CFTR conformational stabilizer, with avacaftor works synergistically on the CFTR F508 delay mutation. So lumacaftor in the clinical study as a monotherapy, didn't show any efficacy on ppFEV1. And previously, in the avacaftor approval, this specific mutation was not approved for avacaftor. So avacaftor itself also not efficacious for this specific mutation, and there's no improvement in FEV1. By combining these two, the efficacy observed in the clinical study was most likely due to the combination use of lumacaftor and avacaftor. So the exposure response for avacaftor supports that the dose of 250 milligram dose is close to the plateau of the dose-response relationship, and the efficacy was demonstrated in the efficacy and safety study in those patients. So therefore, this dose combination, even though there's slightly lower exposure still, 60% lower, so there's no further dose adjustment required. And so the dose at 250 milligram dose was approved in the combination product for avacaftor. So at the end, I think I would like to acknowledge those my FDA colleagues who contribute to the preparation of this presentation, and some of them also contribute to the review for the 2 case examples I mentioned in today's presentation. I think thanks for your attention. I'd like to take any questions.
Any questions for Tao? You stay here. You stay right there. I've got a question for you. So in your experience, you're an older gentleman, in your broad experience, have there been situations where, based upon the pharmacokinetics, you've had to tell sponsors to go back and try a different dose just based upon this exposure response observations?
I think here's the question is, the agency normally will not require the sponsor have to conduct a dose response. So our regulatory actions are normally based on benefit risk assessment. If benefit risk assessment doesn't support approval for a particular product, and we notice that there's a potential improvement can be made based on dose adjustment, then we would recommend the sponsors to go back to evaluate other doses. Otherwise, we may not be able to say that, because if a drug doesn't work well, if there's no dose response we can talk about, then we won't be able to recommend that.
So I just want to clarify. So if a drug doesn't work, you can't make it work? Is that what you're saying? Okay. Are there any other questions here?
I did have one. Hi, JP Clancy from the CF Foundation. As I was looking at some of the data that you showed earlier, and maybe it's not completely fair because I think you were focused on maybe the pediatric extension part into infants, but as I was looking at the ivacaftor data, I was struck by what looked like you had like 20, placebo, 25, 75, 150, 250, and it looked very similar from the 75 to the 250 in my mind. And I'm just kind of curious, how would you go about making a decision or recommendation about the dose to take forward? Because from where I sit, it looked very hard to make a call based on this, the signal that was seen.
Okay, thanks for your question. So I just want to add a little bit more about that case. So avacaftor, for in pediatrics, we had actually some specific concern regards to the liver toxicity and also for cataracts. So I'm not sure if you noticed that, but in some publications, there's some case report. So in newborns, infants, younger kids was developed or diagnosis with cataracts. So when those applications came in, that's a specific concern. So we can ask the sponsor to increase exposure to match the adult and adolescent exposure level, but the safety concern is there. So we have to kind of balance, the potential benefit and the risk, even though we don't know at what exposure level, or it's a prenatal exposure or postnatal exposure that the cataracts develop. But there's a safety concern. So hopefully by keeping the exposure, generally speaking, low, we can avoid some of the adverse events. I think that's the consideration behind the neonates or the infants for the approval. So the flight exposure response, the dose response for 75, like 150 and 250, I think the setup for the adult study, they choose 150 milligram dose. I'm not quite sure if there is a major safety concern for 250, but 75 may also work. So I think generally speaking, if patient can take 150 milligram dose in adolescents, they should take that dose. But if that doesn't work as they have liver toxicity, they may consider reduce the dose to 75. It may also works. But that's like, to me, a clinical practice, clinical judgment.
Yeah, so I just want to boil this down so even I understand it. So here a sponsor has presented you a dose response data set, and 75 looks like 150. And then so why isn't it 75 again? I'm missing that. Why wouldn't you say, gee, why give twice the dose for the same effect?
Thank you. I think as an agency, we do not have the right to say you can only choose 150, right? So they choose 50 most likely to me is that they want to get some safe margin, not safety margin, but they want to keep the drug safe. They have to demonstrate some efficacy. So they don't want to go too low just at the turning point for the dose response. Then in the further clinical trial to demonstrate efficacy or safety, that's a potential risk, right? So they want to keep it a little bit high so that they can secure the efficacy response. But then they don't have to go too high, so they won't have much safety issues.
It still lands in the hand of the sponsor to decide to choose between the risk of poor efficacy and the risk of safety.
Yes. So, I mean, like those responses not mandated in drug development.
Right.
So, yeah.
That was a great talk. I just had one question as we look towards newer classes of therapies for CF, cell and gene-based therapies, which are a bit different development pathway for us. It's an ultra rare population. We don't have systemic biomarkers such as sweat chloride or animal models. And are there examples, perhaps even in other rare disease settings, where the traditional dose rationalization studies may not be feasible to really kind of do all of the different cohorts and so forth, and we need to kind of streamline that a little bit. Do you have any examples or advice?
I think that generally speaking, I think
He cannot give guidance at this meeting. I just want to stress that.
So I think generally speaking, sometimes it's very difficult to have exposure response, dose response in very rare disease population. So you may rely on animal studies. That's one approach. So based on in vitro findings or animal studies, if you can establish such a response or to target exposure level for efficacy, I think that's also can be taken into consideration to support the dose selection. But I think eventually, as agency, we still look into the overall benefit or risk at the end of the clinical trial development to show efficacy and safety benefit. So I think that's part of my answer to your question.
Fair enough. Thank you so much.
Yeah, thank you.
Well done. Thank you.
So I'd like to now introduce Dr. Chuck Esther, who's a professor of pediatrics at the University of North Carolina, Chapel Hill, director of the UNC Pediatric CF Care Center, and his laboratory also serves as CF Foundation-funded Pharmacokinetic Pharmacodynamic National Resource Center.
Oh, just waiting for Mike.
If you're waiting on me, you're backing up. Okay, we're going to find you, and then we're going to go like that. Great.
Oh, perfect. Okay, so good afternoon, everyone. Thank you to Dutch and Nicole for inviting me to come here. I do not have the long list of industry sponsors that my collaborators here have. And as Nicole mentioned, I am sponsored by the CF Foundation for the Pharmacokinetics and Pharmacodynamics National Resource Center. So I wanted to take what we just heard from the FDA and tie it even more specifically into CF therapeutics. And of course, when we're talking about CF therapeutics, lung disease is the primary cause of morbidity and mortality, and therefore most, not all, but most CF therapeutics are designed to address pathophysiology in the lung or the airway. So when you're talking about finding the optimal dose, it requires an understanding of dose exposure response relationships in the lung. And that is not easy. There's lots of issues that you have to deal with when you're trying to develop a drug. What route are you going to use? Are you going to use oral? That's really what patients typically prefer, or inhaled, parenteral. Where are you going to measure your exposure? Is it okay to measure in the systemic circulation? Do you have to measure it directly in the airway? And how are you going to measure the response? Can you use a biomarker in the airway or a systemic biomarker, or do you need a physiological outcome such as lung function? So to try to answer some of these questions, I thought we'd go back and look at some previous approved CF drugs and get lessons from there. So I was going to start by looking at oral drugs. The pros for that are that they are very much patient preferred. The downside is there's an awful lot of organs between the mouth and the lung that all have an influence on the pharmacokinetics and the exposure of your drug. Now, the one positive on that is that you can usually easily measure drug concentrations in the systemic circulation. And at least in this model, you're only one arrow away from the lung. And so you feel like if you're measuring in the systemic circulation, you're probably reasonably predicting lung exposure. Now, for those of you who have been around for a while, and when you start talking about doses and exposures and pharmacokinetics of drugs, probably one of the first things that comes to mind is high-dose ibuprofen. And that's because we actually used pharmacokinetics clinically to dose this drug. So we had a defined dose range, typically 20 to 30 mg per kg, and an exposure target, so greater than 50 micrograms per mil in the systemic circulation. And you would do a little PK study, make sure that you were in the optimal dose range. And if you do that, the clinical trial showed that you did see a response. So slower rates of lung function decline with high-dose ibuprofen, although it was limited to the subset of individuals that were under 13 at the start of the study. Now, one of the challenges here is, well, where did that exposure threshold come from? Well, it did not come from early phase 1, phase 2 trials. It actually was based on in vitro studies and neutrophils and animal models and other data like that. Now, subsequent to the clinical trial, there have been some in vivo studies suggesting that 50 micrograms per mil is the right therapeutic target, but they're not lung function studies. This is actually a study of mouth neutrophils. So they were measuring migration of neutrophils into the mouth. And they show that when you reach that target of 50 or greater, that you reduced migration. And if you were below that target, you didn't have much of an effect. Actually, it almost looks like it's backwards. But there's no exposure response data on lung function. Now, high-dose ibuprofen was a drug that was already approved and was developed by academic people. So what happens if we look at something that's industry developed, where presumably they have deeper pockets and can do more of these PK studies? So I'm going to look at the current components of ETI, so ivacaftor, tezacaftor, elexacaftor, and all this data are my graphs made from data that are in the Center for Drug Evaluation and Research reports, which make for fascinating reading if you're having trouble falling asleep at night. So each of these, this is the dose exposure for each of the drugs. Now, they're from 3 separate documents. This is from the ivacaftor monotherapy, the tezacaftor with ivacaftor, and then the elexacaftor is with all 3 drugs. And you can see there's actually a pretty close relationship, as one would hope and expect, between dose and either AUC or Cmax. It doesn't really matter which one you use. Dose and exposure are very tightly linked. Dose response, it's a little different. So this first panel is actually very similar to what you've seen, just some pretty colors. And I'm also showing both the change in percent predicted FEV1 and sweat chloride. And what you see here is this flat curve from 25, 150, 225. A little bit on sweat chloride, you actually see a bit of an increase at the highest doses, suggesting maybe not quite so much efficacy on that particular marker, although lung function was unchanged. A very similar response to tezacaftor. The overall delta is not as big, where you see a pretty flat FEV1 curve and maybe a little bit of rise up on sweat chloride. And then for elexacaftor, really not much clear dose response at all. The curve's pretty flat. In fact, the middle dose was worse slightly than the lowest dose or the highest dose. And so if we put it back onto Dutch's framework here, we see We probably have a curve where we're either sort of on the flat end of the curve, or maybe it starts to decrease a little bit with the higher dose. So what about, so here are the actual doses that are used now clinically that went forward in the clinical trials, at least for ETI. And you can see, I think what they did is they chose the highest dose. So safety was generally comparable among all the doses. So it's the highest dose that didn't start getting into the decrease in sweat chloride. And for lexicaftor, since there was no evidence that a high dose had a less effect, they just chose the highest dose they tested. So there's exposure response, there's not quite as much. The best data come from ivacaftor monotherapy. And if you look in those FDA documents, you'll see this nice little graph showing that there is an exposure response relationship and suggesting that you're getting into an EC80, EC90 if you're above 250 nanograms per mil. And this is actually a trough dose that they were measuring. But it's important to actually look at the data from which this curve is derived. And it's a little more messy. You can kind of see that even at this lowest dose, 25 milligrams, you had some pretty good responders at these. So this is, you can see they're color-coded by the dose, and then this is the actual concentration measured. You see there's a lot of variability here, and you've got some people with pretty decent ivacaftor concentrations with very little response. So this is really important information to have, and it's good on a population basis, but it's really difficult to say for an individual, for example, that your target should be 250 because you may have someone that responds to a low dose, you may have someone that doesn't respond to a higher dose. So why is that? Why is there a discrepancy between dose, exposure, and response? So there's probably a lot of reasons. One of them may be that the exposure that we're measuring in systemic circulation may not actually be the exposure in the lung. So we've shown in a cell culture model that modulators accumulate in airway epithelia, especially ivacaftor, and in fact are pretty slow to wash out. And then my colleague, Dr. Gimbalot, has shown a similar phenomenon in a human study where the concentrations in nasal epithelia were roughly 10-fold higher than the concentrations measured in the plasma. So it may be that we're measuring our exposure in the wrong compartment. And so I won't spend a lot of time about what the optimal dose. I think Dr. Gimbalot will go into that more. But just to mention that there are several studies that have explored dose reduction primarily for mental health changes. And as a general rule, these are about half the normal dose. It varies a little bit by study. There's not a change in FEV1. Now, these are small studies, and so you don't want to make too much out of it, but it does suggest that possibly we could target a lower dose. Okay, so oral drugs, pretty complicated. What about inhaled drugs? Those should be better, right? Because we're getting rid of all that stuff that's in the way between the drug and our target. So in this case, we're inhaling the drug, it's going straight to the lung. Patients don't like it quite as much, but we have a lot of inhaled drugs that people with CF use, so it's okay. One of the problems is that we typically measure our PK values in the systemic circulation, and now it's not quite as valuable, right? Because we're not measuring the last step before it gets to the lung. Now we're measuring what gets out of the lung and not what's actually in the lung. So that probably means we're going to need to measure things in the airway, and that poses its own set of complications. So airway lumen inhaled drugs tend to be dominated, the PK of those drugs tends to be dominated by mucociliary clearance. This upper right panel is showing an animal study in mice, very rapid reduction in N-acetylcysteine levels after an inhalation. And we see similar studies in humans. These are a couple of studies on inhaled tobramycin, both showing a very rapid peak after inhalation with a decline, perhaps a little bit slower in CF. So this is healthy individuals on the left and CF on the right. So maybe a little slower, but still, those drugs don't really hang around in the airway for very long. And what about dose exposure? Does that? Well, here you start getting into some of the challenge with the airway secretion. So this is data from development of the inhalation powder for tobramycin, and it's compared to the inhalation solution that currently approved. Well, they're both approved now, but at the time. And you can see, so I'll first call your attention to these very big error bars, and probably 56 is a little lower, but when you get to 84 and 112, it's not clear there's an absolute difference between them. When you measure the drugs in the serum, you do start to see a little bit more of a dose response. but the concentrations are much, much lower. So you're talking about a Cmax less than 1 compared to 500 to 1,000 for the other ones. And then similar studies have been done with estrienam lysate for inhalation. In those studies, they figured out they needed to measure their Cmax at 10 minutes, so pretty much like almost immediately after the inhalation. And again, tons of variability. You can see these error bars are just ginormous. And then we tested adolescents and adults were tested in this, and there's just differences between adolescents and adults, which don't necessarily make sense physiologically. You wouldn't necessarily expect there'd be huge differences between these populations, and it's probably just a random variation in the data. Again, you can measure estrienam concentrations in the blood. I think this is plasma in this case, but it may be hard to see, but these concentrations are in nanogram per mil. These are in micrograms per gram of sputum, so vastly different. And then there were phase 2 trials that looked at 2 different dosing regimens, 75 milligrams or 225 milligrams twice daily, and looked at responses. So 2 responses, killing of Pseudomonas, so Pseudomonas density after delivery of the drug, and lung function. And what they saw is, so these were at day 7 and day 14, so these are 14-day dosing and then a 14-day washout. So the higher dose seemed to give you more pseudomonal killing, but when you looked at lung function, you actually saw that the lower dose gave you a little bit better persistence in the effects of lung function. So I was not at all involved. I believe you were. My understanding is this caused a lot of consternation among the industry sponsors here as to what to do. And actually the dose that went on and is currently approved is not either of these doses at 75 milligrams 3 times a day. Here's DNase, another drug where there's a little bit of a dose response at the 0.6 milligram level. You can see, maybe not quite as persistent as you go up, not clear, but a little bit of a hint that there's a dose response here. And when they did the long-term clinical trial, though, of 24 weeks, a very large clinical trial, I think it was over 900 people, you really didn't see any difference between once daily or twice daily dosing. But both are approved, So that brings us to the future. So this is a slide that I shamelessly stole from JP, which shows the drugs that are in development. I think we actually saw this in the plenary as well, for modulator ineligible or untreated people with CF. So a lot of different things, and you'll notice that many of these mRNA, ASO splice, gene addition, they're all what we would call nucleic acid-based therapies. So what do these all have in common? Well, they're all inhaled drugs, but they're not targeted to the airway lumen like a mucolytic or an antibiotic. They're targeted to airway epithelia. So this is different. So what do we know about inhaled drugs targeted to airway epithelia? And the answer is not a lot. There aren't, I don't think, any CF-specific examples of approved drugs that are targeted to the epithelia and not the lumen. So most of our data comes from animal models. I'm showing one figure on the left that we've generated through our NRC looking at an RE1 inhibitor, and you can see the pharmacokinetics are very different. So these are lung concentrations, and they go up kind of slowly over the course of hours and then drop over time. And then I found this horse study on albuterol, but I thought it was interesting and very relevant here because these are lung tissue samples, so they were getting tissue biopsies from horses and measuring how much albuterol, or salbutamol, which is why it starts with an S, because that's what the British call it. And you see much higher concentrations in the central airways than you see in the peripheral airways. And I think that's really relevant to CF because CF at least initiates in the peripheral airways, and probably effective gene therapy is going to need to get down there. But your typical inhaled drug is probably going to be more in the central airway. So that's a challenge that will have to be overcome. So what do we conclude from all this? Well, for oral drugs, the dose exposure at least is pretty straightforward. Exposure response can be a little bit messy. For inhaled drugs that are targeted to the lumen, both dose exposure and exposure response are actually pretty variable, and exposure is not terribly predictive. And then for inhaled drugs targeted to airway epithelia, like what we're hoping to develop for those not responsive to modulators, we just don't know a whole lot at all. And we're probably going to need new approaches for these sorts of therapies that JP will talk about later. And with that, I'll take any questions.
If you have a question.
Don't crowd the microphones. There's plenty in the room.
Thanks. That was a great talk. I find it fascinating and curious that 2 different doses of DNase were approved. How has that played out clinically? Do you think that was a good thing? Should we have been doing more post-marketing to kind of figure that out, or is that flexibility good in the end? I'm just curious.
Yeah, I mean, it's interesting because, of course, once it's approved, we tend to use it however we use it, right? And at least in pediatrics, we tend to only do the once-day dosing. I think in the adult populations, and people here can correct me if I'm wrong, they tend to do the twice-day dosing for maybe more severe disease or during an exacerbation, sometimes even more than that. So I don't think it was harmful. Now, this drug was approved, many, many years ago, so I wasn't practicing CF care in the early days of Pulmozyme approval. So if someone else has more insight into whether that was confusing or not, I'll defer.
Marty.
Hey, Chuck, Marty Burke, University of Illinois, and a co-founder for Systemic Medicines. In the case of the modulators, sweat chloride could be very helpful, obviously, as a biomarker to help make some of these nuanced decisions about dose response. In the last section, what are your thoughts on potential biomarkers that might be helpful in terms of thinking about dose response for direct delivery to the airway? And particularly, can you comment on imaging and whether you think there might be an opportunity there?
Well, we're going to put a grant in on that. So yes, I do think there will be. There's a number of techniques to actually get. So one of the questions is, well, how are you going to do all this? And is something like a bronchoscopic driven airway sample going to be reasonable? And it may be, I think, where we are right now, it may be that we're going to have to do that at least early on in a subset in the early stages. And there are small airway brushes. It gets really complicated because you can't just say whether there's CFTR there. It's got to be in the right spot, right? So if you make a bunch of CFTR and it stays in the Golgi, you may see that staying pretty well, but that's not really a marker of efficacy. So whether you're going to need to do some physiologic measures like Using chambers and then imaging, and then how do you know that? I know my colleagues are developing like different antibodies for different activated states of CFTR, but I think a lot of that's going to need to be done. Right, JP? We need money for doing all that.
That was a brilliant answer, I just got to tell you. Dr. Geller. David Geller, Arcturus Therapeutics, an ex-aerosol dude. I appreciate your comments on the last 2 categories, one with airway or mucus basically as the target, the other one is the epithelial cells as the target. And having spent a number of years trying to figure out the scientific basis of aerosols, I finally concluded it's a lot of noise, it's a lot of variability, and it's very difficult. So do you think rather than trying to measure exposure response relationships, we should just measure the response and the dose and go back to that point and give up on trying to measure exposure since it's so noisy and scattered and variable?
Yeah. I think ultimately probably any real clinical trial is going to have to focus on response and not exposure. I think the question, and I'm not as in depth in this field as probably some people in the room, is with the struggles right now on developing gene therapy, are we going to need to be able to do some smaller trials to actually get some idea of exposure to make sure that yes, this particular therapeutic is doing what we want it to do and we can see some measure of efficacy where we need to see it. I mean, you can see it in the nose, right? That's relatively straightforward, and that's great. I mean, that's important, but can you see it in the airway? So I have a feeling we're going to need to be able to develop that, and I'm not saying that just because I want grant funding from JP. But I do think early on that's going to be helpful, but then ultimately that's not probably, you're not going to be able to do bronchoscopy on 80, 100 people for a clinical trial. I mean, you can, but this is probably not practical. Okay. And it's very expensive.
So I'll just thank you, Chuck. I just want to say that my experience with sponsors is they'd rather have efficacy without a mechanism than a mechanism without efficacy. And so seeing cells light up and no efficacy it's slim solace for these people. So anyways, thank you very much. I appreciate your talk. It was very good.
Thank you.
Okay, it's my pleasure now to introduce Dr. Jennifer Gimbalot, and she is an associate professor and section of pediatrics and section chief at Arkansas Children's Hospital. And she is got quite a cottage industry at this meeting, talking about what she's going to talk about here today too as well. I hope everyone enjoys it as much as I know I will. Jennifer?
Well, thank you. I think with cottage industries, you make money, though.
Yeah.
And I don't think I'm getting paid. So
Call
it's
me.
okay.
Call me. I can work that out for you.
All right. I wanted to thank the organizers and the co-chairs of the session today for inviting me to talk about ETI exposure adjustment in the real world. And so I'm really going to take a different tack today, and I'm not going to talk a whole lot about the clinical trial work, but so much as what we have done in the post-approval world. These are my disclosures, and I do want to note that I will be discussing off-label use of medications because the majority of dose adjustment that we're doing these days is actually not on the label at present. So when we're thinking about adjusting the dose in a clinical setting, we really have two basic approaches. The first is empiric treatment, so basically titrating to effect and managing for side effects without knowing a lot of other information when turning the dose up or taking it down, depending on what we're trying to achieve. Precision treatment is a little bit different, and that's how I became interested in this topic. So precision treatment is really titrating based on known data, and that could include like the CFTR mutation, which we do already. It could include genetic variants that we may or may not know yet that can affect the response, the side effect profile, the concentrations of the drug. We can use blood concentrations for therapeutic drug monitoring or use biomarkers such as sweat chloride and lung function and all the other ones that we use for our clinical trials. And the figure on the right side of the screen kind of illustrates this complexity of what we might incorporate into precision dosing or precision treatment. And I have in the sort of the blue ovals sort of other things that we also might be thinking about or that could contribute to clinical outcomes and drug responses that we may or may not incorporate into this process. The reason that we're talking about dose adjustment today is primarily because of the side effect profiles. It's not the only reason, but it certainly seems to be the most common. And so I've tried to summarize all the different types of side effects that have been noted as in the post-approval era, as well as during the clinical trials in the figure that you see here. A recent meta-analysis in 2023 showed that up to 82% of adverse events for elexacaftor, tezacaftor, ivacaftor, or ETI could be probably or possibly associated with the drug, but only 6.6% were severe adverse events, and discontinuation remains very rare. And there's currently little systematic evidence that directly connects the concentration to the side effects, which, as Chuck has recently shown, the dose and the concentration are closely linked. Despite this, it has prompted significant behavior changes in the CF community, and so that we do have an increase in use of dose adjustment to manage these side effects. Some of these new concepts of dose reduction have come up in the last few years, and one of the first reports of this was from Dr. Spolatini in 2022 that Chuck also showed. And a general dose reduction scheme in a case series was employed that's shown here, and the impacts on the outcome measures are shown here, which I have graphed so that just for easier visualization, and these are derived from that publication. And the maintenance of clinical outcomes was seen in this study for the majority of patients. And the hypothesis that arose from this and subsequent cases and case series was that dose reduction may be a viable option to manage side effects. So today, I'm going to talk more about what is the evidence that we currently have for dose reduction for these purposes, and we can start going through that now. So we've already talked a bit about the effective concentrations, and so just to give it a little bit more detail to provide context for the rest of the talk, I'm going to talk about this a little bit more specifically. And so what you see in front of you is a concentration or exposure response curve, where along the x-axis is the concentration, and on the y-axis is the response. And for drugs, this is, we talked about, as you increase the concentration or dose, you would expect to see for the majority of drugs a gradual increase or some increase in the responsiveness over time until you reach what's called the maximal effect or the maximal response, above which further increases in the concentration are not likely to elicit any further increases in the biological response. And then you fit a model to this using a statistical approach in pharmacokinetics and pharmacodynamics analysis. And this is commonly employed during drug development and dose finding. And the effective concentrations, or ECs, can be calculated from this on a population level to help us understand what doses we should be choosing. So for modulator therapy, this was identified as the EC50 and the EC90 to get a clinically relevant biological response. So in this case, below the EC50 would be considered a suboptimal response or undesirable response. And above the EC50, we would expect to see a significant response in the outcome measure of interest. But for the case of modulators, because so few adverse events were seen, there was a tendency to sort of push the dose higher. And so that was kind of addressing the question we had earlier, that we saw so few toxicity problems and few adverse events at higher concentrations. The goal was to really try to get as many people as possible at or above the EC90 so that the most number of people could experience clinical benefit. Subsequent to that, Dr. Tsai and her group in 2020 published this study, which is some of the most detailed data that we have about effective concentrations. And this is actually based on real data, and it's a simulated data for transitions for one type of modulator therapy to ETI. And in this particular graph, this is actually simulating the transition from tezacaftor-ivacaftor combination to the triple combination. And as I just mentioned, the goal was to try to keep people blood concentrations at or above the EC90 to maintain that clinical efficacy. And the effective concentrations are marked here in green. And then so you can see by these simulations that by the several days after adding elexacaftor to the mix, that goal was achieved. They would anticipate that the vast majority of people would have concentrations at or above the EC90. And so my research group is really interested in real-world data and how that compares to the clinical trial data and the simulated data. And so this is actually data that was simulated by Dr. Acosta, who's my clinical pharmacology collaborator, and derived from data that we published in 2022. This is ivacaftor monotherapy, and it takes real-world data from real people actually taking ivacaftor monotherapy and looked at what it would look like if that group of people started taking ivacaftor after not taking it at all, and how long it takes to get to steady state. And it gives a good distribution of what those concentrations look like from the 25th to 75th percentile. And as you can see, you have three different sort of categories where you have low, middle, and high, but they're all over that EC90, which is indicated in the green box there. And so in our real-world data for this drug, at least, we did see that keeping those concentrations at that elevated level to maximize the response that we could achieve that goal was achieved. On the graph I've shown you on the right is, I'm going to show this a few times to sort of help you understand where we are in the exposure response curve. We're on that flat part of the curve where the concentrations can be driven up higher, but we wouldn't expect additional biological response. And this harks back to Dutch's figure as well, that further supports that dose adjustment in cases like this might be beneficial, and that we actually can slide that dose down so the exposure is reduced, but we actually don't have a detrimental impact on the biological response. Further support for the potential hypothesis of dose reduction comes from Dr. Berengen's group, and this is a slide of simulations of lung concentrations that could provide further support for this practice. So what you're looking at here are simulated lung concentration profiles of elexacaftor, tezacaftor, and ivacaftor using physiologic-based pharmacokinetic modeling. And what Dr. Berenger and his colleagues did was to look at what the range of concentrations may be based on available data, looking at a very low dose reduction, in this case, alternate day dosing. And he looked all the way down to the 5th and the 10th percentile. So you're looking at trying to look at the lowest of the low groups of patients. And they compared that to in vitro EC50s, the effective concentrations to get 50% of the response in an in vitro model. And as you can see, in all three of these concentrations, those concentrations did remain above the EC50. Now, noting that we're now kind of moving along down to that more linear part of the concentration response curve where you are going to have some response, but you may have detrimental response. So there's both support for, but also with a caveat. So further things to think about in clinical considerations for dose reduction is that modeling using clinical research data is very useful, as we've seen through multiple talks today. But it doesn't always tell you very much about an individual in your clinic. You know, what we were talking about with all these modeling and population means is looking at a population of people, but an individual in your clinic may be your outlier, your data point that doesn't fit close to that population mean. So we'll spend some more of the talk talking about what can a single sample tell you and how variable are ETI concentrations that can help inform that one person who's sitting in your clinic in terms of clinical practice. So this is data that I presented in workshop 4 earlier this conference, and also is available on poster 865, work that I did with Kathy Ramos at the University of Washington. And what we did here was look at real-world ETI concentrations. And what we see is that it's highly variable. And so what you're looking at are concentration time curves. These are individuals' drug absorption, distribution, and elimination, and all the patients are on standard dosing. Each line that you see represents a different person. The dotted line versus the solid line are actually two different groups that we studied, and the shaded areas are the estimated effective concentrations. So what you should really take away from these graphs is that each individual is highly different from each other. And not only that, but the ways in which the concentration rises and falls over time is also highly variable, making it difficult to pinpoint a single point in time that will capture all three of the compounds at the same basic level. Meaning, if you pick one time point to try to get a trough for all three of them, you might have a hard time doing that. And the same thing if you try to pick a single point to get the highest concentration. The other thing that's highly variable in the practice of dose adjustment are dosing changes. They are also highly variable and non-standardized across the community. So this is a study that I did with my postdoctoral fellow, Natalie Rose, who's shown there. And we were actually interested in why people might want to do therapeutic drug monitoring and how they were approaching that. And for the standard dose patients that were in our study, they were mostly experiencing some form of of lack of response. But for those who had reduced dosing, it was primarily due to side effects. And what we did here is that we calculated a daily dose equivalent because there were so many different dosing strategies that were employed, it was difficult to compare them. And what you can appreciate from this graph is that there were significant amounts of total drug that were provided for each compound to individual patients. The dosing changes were really variable, as I said. Some people would stop evening ivacaftor, reduce the morning combination to a single tablet, swap evening and morning dosing, moving to every other day dosing or other things, but very non-standardized. And we were also interested in what these specific changes in dosing did to concentrations. And so that's shown here. And what we showed here are the patients in standard and reduced dosing and what their concentrations were. And as the first thing that should stand out to you is that these are, it's a small sample size because this was a pilot study, and the responses are highly variable. But what we noted particularly was that when compared to the concentration means for people who responded well to these therapies, the people on reduced dosing were getting far less. In fact, when harking back to the exposure, effective concentrations, we found that 25 to 50% of patients had concentrations below the EC50, and 87 to 100% of people had concentrations below the EC90. So again, on that linear part of the curve where we can potentially expect to see detrimental responses or suboptimal responses on the biological measure that we're looking for. There are similar findings have been seen in the National Jewish Health Laboratory's Advanced Diagnostic Lab. So Sylvia Caceres, poster 134 in workshop 25, and Jerry Nick kindly provided this figure here. And this is from their validation study and with the black dots where they looked at people on full dose, and then clinical samples that were sent from all over the country on full dose, which are the red triangles, and then modified doses in the blue and green squares. And I think what you can appreciate from this, again, is that in real-world use, the concentrations are highly variable. But you can appreciate that some people on a reduced dose maintain concentrations at or above the EC90, just like what the goal was for the original clinical studies. But you also have a substantial number of people who were below the EC50 where suboptimal responses could be anticipated. So again, you're looking at two different areas on the exposure response curve where you may be sliding either from one dose to another that has no effect on the biological response, or you could be sliding down that slope into a suboptimal response, depending on where your individual patient is. So that brings up a question, is there a lower clinical response, or are there lower clinical responses with lower ranges of concentrations? And so we do know that there is a relationship between the exposure and response, but in the real world, it's not always exactly the same or as clean as what we might think in the clinical trials. And so we're looking at two different options, which are shown here. And that would mean that if we slide along that flat part of the curve, that we should see no relationship between the concentration and the biological response on that level, but we might see a relationship if you're moving on to the lower part of that exposure response curve. And that's exactly what we actually see. And so what I've done here is I've pulled out the data from those concentrations that are on the linear part of the exposure response curve. And this is a study that I actually presented here in 2020, or in the CF conference in 2022, from a pharmacokinetic sub-study of the Czech study. And we do see a clinically relevant association between the concentration and response, and it is statistically significant. And we've performed a number of sensitivity analyses as well. And we do, in fact, see that the lower the concentrations are, the worse outcome is for sweat chloride. So what this means on an individual level is that as you slide down that linear part of the curve, you can't guarantee that your patient is going to have a decreased response, but you do have an increased probability that that response will be decreased. So there's a variety of evidence for and against dose reduction based on what we currently have. We do have a lot of people who have very high concentrations who could tolerate a reduction. There are limited case series that suggest it may not cause clinical deterioration, and there is some anecdotal evidence of improvement of side effects. But the current evidence is fairly low quality, primarily limited to cases, case reports, and case series. And most studies utilize sparse sampling. A single sample often is what's used if pharmacokinetic data is checked at all. Sample sizes are very small, and more evidence is really needed to clarify these relationships in real-world use. So what can we do? So we need to improve our study design to understand these relationships. Longitudinal studies where we get repeated measures can be very powerful, especially in our small sample sizes that we have in our population. Using sparse sampling with larger sample sizes will allow for better evidence. For single data points based on our own data, you may need 85 or more participants to see these relationships and understand these differences. But if you do more intensive sampling, you may reduce that sample size needed by about 30%. We require better predictive modeling. We can use intensive data sets to help understand which time point is the best predictor for our PK parameters of interest. In this case, I have shown some data from my studies that show that there is a tight correlation between different time points. In this case, I've shown 0, 4, and 6 hours, and the average concentration, which is a measure of overall drug exposure and what was used primarily to determine effective concentrations for ETI. But note that this data is within the same group, so we expect that it's going to correlate pretty well. Better predictive performance analysis using multiple groups and multiple data sets to estimate these PK parameters will tell us how well they actually predict these PK parameters and give us more information that we can use clinically. We also need to validate the effective concentrations with a larger controlled data set, such as check and promise. That's data that is ongoing now, and hopefully we'll have some results next year. So this conclusion with the sum total of the evidence that we have to date is that we don't really currently have the tools to convert a blood level to a concrete conclusion for clinical care, which means that therapeutic drug monitoring is not quite ready for prime time to help us with dose adjustment. And we do have a lot of uncertainties associated with empiric adjustment of the dose. So if we use it, we should use with caution and monitor in multiple ways and not hold things like a single blood sample or a single time point in clinic as our definitive answer for whether dose adjustment was appropriate. We also really need to have a better understanding of real-world steady-state kinetics. We need to understand the exposure-response relationship and concentration changes over time. And especially, we need to understand the role of metabolites, which was a little bit beyond the scope of this talk. For all three of the compounds, they have at least one metabolite that is biochemically active and capable of either potentiating or correcting CFTR, sometimes at a reduced amount or at the same amount as a parent compound. And we also need to have predictive data validated in populations. That's going to be really key for us so that we can understand if we're doing therapeutic drug monitoring to help monitor dose adjustment and evaluate our exposure response relationships, that we know exactly when we should take a sample and how to interpret that value. So I'd like to take a moment and acknowledge all of the participants and research teams who make all of this work possible. I can never thank everybody, but I try, and they're shown here, and numerous other colleagues and collaborators around the world who contribute to the conduct of these studies. So thank you.
Questions for Jennifer? While JP is sauntering to the mic, I will ask you, for an individual to become a candidate for dose adjustment, presumably this is a tolerability that starts this process. And I just want to make sure I understand. So you've got a patient that's got a tolerability problem, but if I've got your thought process right, what you want to do is look at their current concentration relative to the established data and say, how much could we drop this dose and still remain where there's a probability of response? Does that mean you're not titrating away the tolerability problem? I mean, I would just think you would just start dropping until you don't see the tolerability issue, or is that really naive?
I mean, so that's basically, I think, what is the approach currently for people who use this practice, that you basically just titrate to your effect. It's empiric adjustment.
Right.
We don't quite have the tools to use therapeutic drug monitoring yet because we don't know,
Right.
if you pick a trough. So I presented some of this data about how difficult it is to pick a specific time point in set symposium 5. And so, picking that specific time point and when of the day and what's going on with the patient, and maybe if the moon is in the sky with the constellations just so, you'll know, what it is. But it's just really difficult to know what you're getting with one sample. And so I would say that, right now, empiric adjustment is the main tool that people have. And then using the concentration data can be potentially helpful, but it's very difficult to interpret at this time.
So I probably don't understand this, but I'm comfortable with that. If you titrate someone down to the point where they think it's tolerable, what for your monitoring, if you got it perfect, you'd still be using population averages for
That's right.
different outcomes. And what we, I think, have seen for the studies we've looked at is that these biomarkers and clinical responses all don't go together. There are people that have good sweat chloride and poor FEV1 and conversely. So you really, I guess you're increasing the probability that they might have benefit at the individual level, but there really is no N of 1 thing that you can do that says, yeah, keep taking this because you're probably benefiting. I mean, it's just a probability thing.
That's right. I mean, because what you're dealing with is variability in your biological response measure. You have extreme variability in all of the biological response measures that we have. You have variability in the concentration, and then you have variability in the doses. Yeah. And so you're dealing with so much variation, and it's so broad that it's difficult to pinpoint. And so that's why I say, don't put all your eggs in one basket and one marker. Don't, put all your faith in just one plasma concentration, because all of those things are quite variable. But if you have repeated measures and you keep monitoring, you may be able to titrate that down. If someone experiences a clinical benefit, you can say, okay, well, our sweat chlorides are low and they have remained low. Our lung function is good and it has remained good. Sure. And we see no additional symptoms that are arising, but we also don't completely understand the long-term association of these measures with, are we shortening the lifespan by doing this? Right. We just don't have all the answers. I'm not saying it's universally bad. It's just we need more information so we can do it the right way.
Right. JP.
Really nice talk. Thanks, Jennifer. So 3 drugs, each one has its own metabolism, each one has its own levels. And I'm wondering how you think about this more than I do. So I'm kind of curious, if you're bringing down, if you went and measured the PK on a given person, do the 3 drugs tend to run as a team, they're high across the board, or is it vary from person to person? And the other question I have is, if 2 out of 3 are above EC90, is that good enough?
This is a wonderful question. I have spent a lot of time thinking about it, as Nicole well knows, because I haven't yet published my check PK paper, and that's what's holding me up. So there is collinearity between the concentrations. Tezacaftor is a little bit of an outlier. It acts differently than the other 2, and elexacaftor and ivacaftor tend to run together more. But on a population level, yes, they're highly correlated. For an individual, that is not the case. And so I'm currently analyzing the check PK data for that very question, when you do have discrepancy between the 3, because we do see that, what does that mean, if anything at all?
Thank you very much, Jennifer. Well done. Very well done.
Well, it's my pleasure to introduce Dr. John Paul J.P. Clancy, who's the Senior Vice President of Clinical Research at the CF Foundation and also a Professor of Pediatric Pulmonology at Cincinnati Children's.
Fortunately, not anymore. but I was.
Oh,
It's okay.
that's what your bio says.
Did you get fired like today?
No, that's okay. Don't worry. Our website's a little out of date, so I apologize for that. Anyway, no, thank you so much. I really appreciate the opportunity to talk. Thank you to the organizers. My hope is to bring home a lot of thoughts that have been, or really, actually really great ideas that have been brought forward and data shared, and start thinking about how this might apply to this future state that we are entering and trying to develop inhaled therapies to treat the underlying cause of CF. I was kind of chuckling since I do not have any personal disclosures, but I do admit that I do provide support to many people who have presented today. So I don't know what that means, but you decide for yourself anyway. I hope that doesn't matter. Anyway, so we're talking today about really developing inhaled therapies, and certainly nucleic acid-based therapies are a critical part of this, but not the only part of that. And the good news is that CFTR modulators are extremely effective and have really changed the whole landscape of CF care and CF outcomes, but it's crystal clear that it's not for everybody. There's a large proportion of people who are benefiting from modulators to varying extents. I heard a couple of really nice talks today, 3 actually, talks that really focused on some modulator PK and PD. And obviously there is a subgroup of people with CF that we're all thinking very hard about developing therapies that will treat their underlying cause of CF or really be transformative, hopefully in the ways that modulators have been for the majority of people with CF who have access. This is a small group. We know that. You're going to see iterations of this slide. You'll see some slides coming up that you saw in Dr. Paluski's talk yesterday. And point is, we're trying to make the point, is that this is a small, finite group that we are seeking to develop and bring these drugs to. But they're also perhaps going to lead to truly curative therapies. So they're playing a really important, critical role in the whole development of therapies for people with CF. And there are a number of therapies in the pipeline, but if you really think about the exposure response characteristics, some of the concepts we've discussed today, how does this really apply to designing trials and how to advance programs in that kind of landscape? And yes, you've seen this before, a number of different nucleic acid-based therapies in development. I also call out a small molecule approach, but there are other therapies that are under consideration for development here that really target the small population of people with CF, and therefore I think this applies to a lot of those programs as we think about this. But if you look at just the snapshot of the moment, we got 9 sponsors, we got very different mechanisms of actions and some unique populations within this very ultra-orphan population. However, there are some similarities that help me think through what might be some logical paths forward. So taking a moment to just, again, highlight some of the things that were brought up by Chuck. Thank you so much. You really were a perfect setup for a lot of things we're going to talk about. Topical therapies delivered to the lungs. We would love to have genetic therapies, nucleic acid-based therapies that are systemically delivered. We're not there today. We may be, but most of what I'm talking about today is really focused on pulmonary delivery. And the goal of these therapies at this time is to increase CFTR expression in airway cells. Not every airway cell is created equal for the purposes of restoring CFTR function, but just broadly speaking, it's the airway cells, we believe. And we probably are only going to see benefits. I mean, we may get lucky, but most likely we're going to see benefits limited to the lungs, be that increases in lung functions, reduction of respiratory symptoms, or reduction of exacerbation risk. But unfortunately, as already highlighted by Chuck, we don't really have good PD or PK things to monitor, and there's a great deal of difficulty in really measuring this effectively from the airways themselves. So we don't exactly know how much efficacy we are going to see. We're going to make some estimates, but we don't know for sure coming in today. And, how this scenario of conditions, how does that really apply for us to try to establish exposure response in those early phase studies that are going to really determine what the later phase study should look like? The good news is modulators at least give us an idea of what's possible. They give us some benchmarks, goalposts, call them what you will, but they at least tell us what is possible when we restore CFTR activity into a large number of cells within the lungs. And think of them potentially where we stand right now probably is the maximal magnitude. We hope we can keep moving that maximum, but this, at least based on where we are today, this is probably the maximum that we could hope for. And borrowing again from Dr. Van Deventer's example here of just a very basic dose biologic response relationship here and applying it to data. There are plenty of data sets we could use. This is data from the PROMISE study, just looking at improvement in percent predicted FEV1 at 1 month in people with CF. And you can see that there's this very clear response. And perhaps because aerosol therapies are not likely to get the exposure across all lung units because of inherent CF problems, mucus plugging, structural damage, et cetera, maybe we should estimate a little bit lower. All right, maybe don't go for the maximal effect, but perhaps we should be thinking in terms of call it an anticipated aerosol response region. I don't know if that really deserves the AARR moniker. I doubt it's going to stick. But the point is, there's a place, that you could argue exactly where it is, but somewhere above zero, somewhere below sort of maximal effect we've seen with highly effective modulators. We really only have about 3 pulmonary outcome measures that are ripe at the moment. And we'll talk about some of the other ones, but these are the ones that are established, understood by regulators, obviously been used a lot for studied planning. And I think everybody here is pretty familiar with these. And I'm just going to show you common pictures, different sample size estimates of these different endpoints with different power calculation or power curves shown, 80% in the black, and the open circles are 90%. And we have that estimated sort of region in the blue across these different outcome measures. And on the right are some of the other benchmarks that we have from different modulator studies. And you could move those arrows up and down a little bit, but the point is, you got an area, somewhere above what we saw with Orkambi, probably, below what we see with ivacaftor or ETI. And when you look at these and start thinking about sort of to see effects that fall into that, hopefully that sweet spot, you get the idea of the numbers that would be required for those types of studies. And you can see that the FEV1 is probably the only one, honestly, that's going to perform well enough, particularly for selecting a dose. And, you can debate exactly how wide those little red boxes should be. But point is, that may be feasible. As we look over at the ones to the middle and the right, that gets to be really difficult. And just to make it really complicated, the CFQR respiratory domain, the difference between ivacaftor and ETI was huge. So it's very hard to know really what we should be aiming for. So I hope, and then finally over on looking at the risk of exacerbations, would love to do it. It takes a year, and it's going to take probably well over 150 patients to be able to see that difference. So you can quickly see that this becomes really difficult to really utilize for the purposes, or some of these for utilize dose selection. So I would put forward, and maybe not surprisingly, but that percent predicted FEV1 is probably the only tractable clinical outcome measure for making decisions about dose-response relationship. I will take a moment to just say, where are these other outcome measures? I think they could be supportive. I think it depends on how they're used, and we'll go through some of the recent data on this, but I think at the end of the day, are they really going to improve on what you're going to see with spirometry at this point? We don't really have those benchmarks in the same way for these outcome measures that we do for FEV1. I hope we get them, but we probably don't have them today. And we don't have the data that really links the biomarker responses to the sort of clinical efficacy measures that people really rely on for regulatory decision making. And finally, I think there's lots of room for airway expression assays and development, but exactly how to link that information to benefit is still in the works. And so I'll go through a few just quick studies of recent data that hopefully give you an idea where we stand. I did want to highlight the RECOVER study, which has been a really wonderful study conducted in the UK and in Ireland. Has some similarities to the PROMISE study, but really what I love about it is it had included outcome measures that were not included in the PROMISE study. And you can see the background here, and not a huge study, but it did include people over the age of 12 and F minimal function and FF people, as you can see by the open and blue circles. And you can see the outcome measures at the 6-month and 12-month points, and had robust FEV1 benefits, robust reductions in sweat chloride. The people who were F minimum were new to starting drugs, so you saw sort of larger changes in this group. But one of these things you saw in this population was MBW and LCI improvements. This isn't the first time that this has been seen at all. It's been applied to a lot of pediatric studies, but this is one of the first times that it's actually been applied to a study that included adults with CEF. And I bring that point up is we just don't have a lot of adult CF data at this point. So I think there is definitely potential, but that data needs to be generated. And I did also just highlight some of the outcome measure from the chest CT that was included in that study, and included measurements at baseline, 12, and then they've already gone out to 24 months. And again, these are all from the Pragma scoring system. There are a variety of different measurements that can be done. I just included 3 here: percent of total disease, trapped air, bronchial wall thickening. Perhaps those would represent perhaps more dynamic measures from the lungs. But the point is robust signal in both of those patient groups. And so I do think there is some real potential there, but at the same time, I think there's more work, particularly bringing it to our adult studies. How about mucociliary clearance, or MCC? Again, this was highlighted yesterday in Dr. Paluski's talk, so I won't spend a lot of time on it. But it is a measure of basically clearance of a tracer from the airways. And I don't know if Scott's here, but he described this slide as his career in one slide. But basically what you're looking at is the relationship between improvements in whole lung MCC clearance at the 60-minute time point. That's what's on the x-axis, and the y-axis is lung function. And these are a variety of different interventions: lumicaftor, ivacaftor, hypertonic saline in pediatrics and adults, ETI, and then ivacaftor. And you can see the numbers of people included, and they're all sort of feasible for the types of studies we're talking about. I would say the biggest challenge we run into is numbers. We have 10 sites in the world. Scott's done a wonderful job, as has the whole team, to go from 4 to 7 in the US to 10 internationally, which is great, but that still is a significant limitation to using this for as an outcome measure. I will say that at least in terms of data generation, the REACH study, which probably many of you have heard about, has recently kicked off. But just as a reminder, this is a study that is focused on people who are currently not taking modulators. We hope to enroll up to 400 people over the age of 12 years. We think it's going to serve a lot of important roles, one of which is, we hope, it would be seen as potential external control data that could be applied to a variety of different therapeutic programs. I'm happy to say the first patient enrolled was last week, and so it is officially up and running. And you can see it's a 4-visit study, and it looks very complicated here, but basically monthly check-ins by home spirometry and questionnaires. You see the stars of the actual visits where there's study PFTs, questionnaires, and so forth, blood collections. I just want to highlight that we are actually capturing MBW, LCI, and mucociliary clearance at several time points throughout the study as a sub-study. So obviously not everybody's going to be able to do this, but hopefully this will generate some of that important background data in the study population that we think is relevant for the development of these nucleic acid-based therapies and other related therapies. And then I'll just spend a quick moment on biomarkers of airway cell transduction. Again, there are lots of ways to do this, and I think there's a lot of enthusiasm for this. I just highlight in very broad strokes two that at least have been applied to clinical studies, including detection of mRNA and trying to detect and quantify protein. There are pros and cons. Again, you can probably read them as well as I can, but the points are a couple that I wanted to make is One of the things that is a little bit of a challenge is the brushings that we're doing that could be done are really pretty proximal. Yes, you can go out a few generations of the airway, but is that really going to be relevant to where we think a lot of CF disease is, which is really much more peripheral? And I think actually that slide, where'd you go, Chuck? That slide of the horse slide of the salbutamol was really telling in my mind. You know, if you are looking here, but you really need to know what's going on down here, how much does that really inform you? But you definitely can get some really, exciting data that can at least be applied to demonstrate we're getting to the target cells of interest, and we're seeing RNA, we're seeing protein. It kind of depends on what you're doing. I think the value of, as an example, measuring RNA in an RNA program, probably a bit limited. It really is not going to tell you a lot about whether that mRNA is being used. And again, it doesn't look at function either. And then I think the protein work is coming along, and I really, I congratulate companies who are working on this. This is not easy, trying to have reliable assays that detect CFTR. These are just some pictures that were taken from lungs of people without CF from the CFT lab, and these are just immunofluorescence studies. And you can see in green is CFTR across these different panels, and in red is a marker of a second cell type, ionocytes in the in that second panel, club cells in the middle, and then secretory cells, which we think are all important targets. So I think, yes, you might be able to show demonstration of CFTR in cells of interest. However, how to really equate that into a clinical outcome measure, a physiologic response, is the work that's ahead of us. Finally, I'm just going to talk a little bit about placebos. Most studies that have, in fact, all studies by and large for CF drug development have included placebos, and appropriately so. It's really a very standard part of drug development. Do we really need them? I think is a very fair question as we think about these studies, at least in this phase, when we have a reasonable idea of what we're trying to look for. As we talked about before, studies like PROMISE, RECOVER also showed a very clear improvement in lung function that did not require a placebo. So definitely giving an idea that a certain level of lung function improvement probably doesn't necessarily require a placebo to capture. And if we go back to the picture before that was shown before of looking at lung function change and sort of looking at that response region, you can certainly set up your lower bounds such that you could feel confident that something that exceeds that is a real drug effect. And again, that's really based on the experience of a number of studies that I think we've make us feel that really is tractable. And in the term, to show some examples, it may not be necessary to have that placebo condition to really understand this relationship. And as highlighted before, we do think there may be a role for external controls, but obviously that's work that is in process. So if we start applying this to a clinical development program, here we have a drug of interest in phase 1, going through a number of different dose escalations in the bottom, kind of moving across from left to right. And we hope that we've identified a tolerable dose, highest tolerable dose you can see there. And in phase 2A, one approach would be starting with that highest tolerable dose, and do we see evidence of measurable efficacy based on our sort of determined aerosol response region that we see here. If we do, yay, that's great. And what's the next step? Well, that's where perhaps you go, instead of moving up, you move down. Maybe that's the place where you go to a lower dose and look what type of response you get. Could be very low. That'd be great. That would show you a crystal clear dose-response relationship. Could be in the middle. That's also probably great. You may not need to have a clear separation, but just showing that there's maybe a trend in one direction. How about if we saw some conditions where maybe you were at the wrong part of the dose response curve? Well, perhaps that's a situation where you may want to actually work down to a lower dose. But really, why are we thinking about this? Because we have to be a little bit more creative if we're going to take some of those really exciting early phase studies and be able to successfully progress them to later phase and feel confident about the results. So some caveats. We've made a big guess at what a good response looks like. I guess we could say at this point, if we don't see this type of response, do we want to go forward? That's a philosophical question, but I think that that's at least one worth asking. if we don't really have a good estimate of what response variance is looking like. We're talking about systemic therapies that improve CFTR function through modulators and trying to apply that to inhaled therapies that restore or provide new CFTR. So the variances may or may not be exactly the same. And if it's larger, unfortunately, we probably need bigger studies. And then finally, we may not be completely comfortable with just 2 sequential active treatment cohorts. And in that case, it certainly could include additional for things that look the most promising we'd want to take forward. So summarize, there are a number of aerosol therapies. We're thrilled, absolutely thrilled this is where we are. Again, lots of different strategies, many of them having a very common goal of improving CFTR function. It's going to be hard. It's going to be really hard to have a clear exposure response relationship established due to numbers. We acknowledge that, and we don't have the luxury of a lot of those systemic markers that we would use if we were developing some sort of a systemic therapy. And then the respiratory responses from modulators, they're helpful. They're a great guidepost, we think, and it could at least give us a sense of what is potentially attainable. And it may be able to help us set up some, levels of treatment effect that we would think represent real treatment effects with relatively small numbers. And then finally, that it is time to be creative. I don't think we can rely on the old playbook. I hope that message is coming through. And we are certainly working with regulators to sort of understand this really completely changed landscape of CF and drug development compared to what it was just 3 to 5 years ago. So I just wanted to say thank you. Happy to take any questions from anyone. This was not all my effort. This has definitely been a village contributing to this. I think I can safely tell you, though, this is kind of the CFF perspective on things, if that makes sense. I remember when you mentioned earlier, this has to be your own. I said, actually, I think I can speak for the CFF. This is fair. We think this makes sense, and this is really going to, we hope, be part of the conversation going forward. But lots of other contributors in lots of different ways, but I just want to say thanks. Happy to take any questions.
Thanks, Jake.
I had 2 questions.
Yes.
So Dr. Liu mentioned the role of potentially animal models to help sort this out. So I'd love your perspective if you thought there was any pathway for that. And then the second question had to do for NABTs. Once we establish the initial dosing, what do you think about redosing?
Depends, yeah, good question. So the first one about animal models and perhaps their role to play in this, and anybody who's really smart, please, you don't even have to be that smart. You got any good ideas, please jump in. I would say that in my mind, I've always felt, okay, this is me talking, not the CFF, all right, but no, I do, I've always felt that if we're gonna really going down the road of editing true genetic changes as opposed to an addition that's transient or something like that, probably gonna have to cure an animal before you can cure a person. Because of inherent risks that come with these. And, I think you can debate that and so forth, but I think when we're talking about editing, super exon insertion, things like that, my suspicion is that people are going to really want to see that an animal was cured. So in those extreme circumstances, I think that's probably going to be necessary. That may change, as the fields evolve and go forward. I guess I would say that, I think the animal models are, being able to show benefit or show measurable effects is great. We don't have really great translation. That's the problem. The PFTs on a ferret are not the same as PFTs on a person, believe it or not. I think there are some cool things. I saw some nice work with mucociliary clearance, which I think is really cool, but it's still not exactly the same. It's a kind of a different, I know these sound like nuances, but doing these respiratory measurements are sometimes really hard to translate across animal models. So it's a long way of saying, if we could find something to translate, yes, I think it'd be great. I do think they'll obviously get to play an important role to know the cell types, the distribution, the potential evidence that you're having cellular uptake, but I think they at the moment, can only take you so far. So.
And redosing.
Oh, redosing. Depends. mRNA is redosed quite a lot. We're learning and see how that looks. I think redosing is a big question mark for any protein-based therapy. I think we all know that. I think. And what did you want to know about redosing? Was it?
Oh, do you anticipate we would use the same doses?
Oh, would you use the same dose?
Through this process again.
Yeah, that's a good question. I don't. Yeah, I would.
Nobody knows. That's
Nobody
more
knows.
of a philosophical question.
I know.
We just wanted to trick you into answering.
Well, I would think that a combination of, well, what needs to be done is understanding, to be able to redose, can we tolerize people with, by some, I'm going to say gentle manipulation of the immune system that would open the door to that, and then we could ask the question about what's the right dose. So, fair. Dave?
Question here?
Yes, sure.
Hi, I'm Harald Kögler from Boehringer Ingelheim. I actually don't have a question for you, JP, but would be very interesting to get Dr. Liu's perspective from, on behalf of the agency, about the thoughts of a placebo-free pivotal trial. I like this idea very much, but let's see what your position is.
You can come here or go there.
I will say it's not wholly fair because most of what I've talked about is CBER with a B, which is the Center for Biologics and Evaluation and Research. So there hasn't been as much space, but I certainly feel free to jump in. But
First of all, I think, generally speaking, placebo-controlled study is required. So you have to consider what forms like adequate, well-controlled trial. So adequate, well-controlled trial is basically the requirement, but it unnecessarily has to be placebo-controlled. But right now, if without a placebo control, I'm not quite clear what kind of forms the adequate, well-controlled trial. So I think that's a basic question. So if under certain circumstances, like you have real-world evidence data, if you have like very strong efficacy that you can justify, for example, we won't be able to see it in the placebo anyway. So this is a huge effect. That may justify like without placebo control, there's also can demonstrate efficacy. But otherwise, I think it would be difficult to distinguish whether there's a placebo effect or there's actually a drug effect.
yeah, I think it's a great question. We have started some conversations with members of CBER primarily, but also Dr. Petrozzoni from CEDAR about very conceptually about the role of external controls in drug development. And I think there's an openness to that. And there are some precedents to which I think people are familiar with. So I'm hopeful that the door is open, and we're going to continue to work on keeping that and pushing that door open. So thanks.
Yeah, and I will say the Accelerating Rare Disease Cures program has invested a number of programs into external controls, and so they're extremely, I think, intrigued and interested in the development space that we're facing with cystic fibrosis and exploring whether there is a role for external controls for our development path.
And I just want to stress what we've talked about here today is largely risk reduction for sponsors, where these are not pivotal trial designs that we're proposing. These are ways to rationalize a single dose pivotal trial, which would be adequately controlled, but would be foolish not to run a trial that the agency thought was well controlled.
We got to get the agreement of what exactly that looks like. But anyway, David, yes.
Thanks, David Geller. I want to thank the Foundation for taking on these very difficult, challenging questions. And one of the things that you and Nicole and several have brought up are these power curves to try to figure out, what the patient population would be in a pivotal trial to show efficacy. However, to get approval and to really file for an NDA, you also need a safety package.
Yeah.
And so the question, and that's why I didn't want to let you go, is because CF is a rare disease, but historically you've needed like a minimum of 300 patients with 6 months exposure, 100 patients with 1 year exposure as a minimum safety package. But with a subpopulation of that, it becomes a rare disease. A lot of rare diseases have, maybe pivotal trials that may go as low as 20 or 30 patients, depending on the disease. So I just wanted to see if Tao had any opinion, his own personal opinion, about what the package should include for this kind of population, for a pivotal trial.
So before he tells you what he thinks, I just want to point out that depending upon the risk associated with the therapy, it's always possible to generate a safety dossier outside of your target demographic. So for instance, with ivacaftor, there was a large safety study run in Delta F homozygotes. So I don't think we would do that for gene therapy. In fact, I certainly would not do that for gene therapy. But for, say, the oligonucleotides, it would be completely reasonable to increase your safety data set with people that were taking modulators if we're really looking just for a safety signal, I think. That would be what I would propose to the agency. Now the agency can tell me what he thinks.
So my personal opinion. So for safety, there's no magic number. So you have to get 300, you have to get 500 for like how many years. For rare disease, most of the time you won't be able to have a like large safety database. So I think it depends on a couple of things. One, if there's a non-clinical safety issues, like in animal models, if you see any particular safety concerns, and also like in clinical trial, if there's any major safety issues observed. If the safety database is quite small, meaning the patient population number is quite small, then you won't be able to get large number of safety populations. Like post-marketing safety surveillance can also be required after approval. So then you can get like track the safety profiles like post-marketing and see if there's any safety signal when you expand the patient population. That's another way that we can eventually address the safety concerns.
Now you can go.
Thank you.
No, very much appreciate your clarifying that. Thank you.
Okay, we'll take one last question, and then Dr. Clancy can head to the plenary to get ready.
Hello, hi, Benjamin Gossert, Flagship Pioneering. Thank you, Dr. Clancy, for your talk. I had a question about how the CFF was considering things like organ chip models and stuff going forward, since one of the main issues is translatability issues, but when we have something like an organ chip model that can do functional forces and things like that, how does that play into how we sort of scale up these preclinical testing models to give us more assurance when we get to the clinical trials?
Yeah, it's a great question about what the role of some of these really emerging kind of preclinical models, systems, how they could apply to sort of development plans. To be completely transparent, we don't know what's the translatable model now. Modulators, we were very fortunate that studies conducted in human bronchial epithelial cells ended up being quite predictive, thankfully. We're not there with genetic-based therapies at all, unfortunately. We are relying on those models to some extent. We like to see that there's evidence of human cell tropism, and it's usually coupled with additional studies that have been done in animal models. I would imagine that it's going to be some triangulation that includes models that are in place coupled with a new emerging preclinical model systems. Until we have something that really has some traction, we're going to be struggling, to be honest with you. So I know that's a non-answer, but I would probably tie it into some of these other models we're using. And as we start to see some efficacy, and I think we will, that's going to inform what the models need to look like.
And if I can just expand, always we're looking for opportunities to use less animals and be more accurate. That's always the case. But we're really in a situation, crisis is too strong a word, but we really have a very serious situation here where we've got a number of therapies that we'd like to test, and we simply don't have the people available to be able to use the old methods of getting to phase 3. So this is a pragmatic discussion that we're having, and we're not having it with the FDA, of course, today, because the FDA isn't here. But this is a continuing discussion between all the stakeholders about how we can solve this. We have a pinch in the system. We've got more therapies than we can study, and we don't want to choose one. We want to have everybody, we want the best one to win. So, it's not as glamorous as organs on chips, but it really is a central problem that we need to solve, and that's the purpose of discussions like this.
All right, I would just want to thank all of our speakers today. Thank you for coming, and I hope you enjoyed the session.
Thanks all. Appreciate it.
Good job.